And yeah, man, this is gonna be good. Thank you again.
How can I support you, man? You're doing good work, and I want to get the word out.
And I was just talking to my wife about this. I think the best way to support is always just getting the word out. I want everyone who has a specific diagnosis to get to know somebody else with another, so that we know we're not alone in this.
People will look to you and trust you because of the virtue that you share the same ethnicity or skin tone or what have you. You can kind of be the entry point for people to have access to someone who may or may not look like them, but is telling them something that's real and needs to be listened to, that's trustworthy and not something that's going to be like another Tuskegee experiment. You have a lot of power alone, and bringing somebody on who knows kind of the science side and can speak to it in a way that you trust and you get to vet them is extremely powerful.
I didn't have the strength that I have now. That's when you really need people.
People who could understand.
It really did make a difference.
So finding that community, finding that tribe.
Or in that realm of chronic illness and stuff.
I barely go through it because I'd be so focused.
Never thought in a million years that would have to happen to me.
All those emotions are valid. Yeah. Every last one of them.
I was at a low point.
Just kind of removing the stigma.
Ladies and gentlemen, this is the Chronic Brew. Welcome back to the Chronic Brew. You know, we talk a lot on this show about the gaps, those frustrating spaces in healthcare where the patient feels like they're falling through the floor. Well, today we have someone sitting at the table who sees through those gaps at the very top of the medical field. Dr. Bilal Ahmed is an interventional and structural cardiologist. That means he spends his days doing the high-stakes, heavy-lifting work of fixing the literal architecture of the human heart. But what makes Dr. Bilal different is that he refuses to stay inside of the sterile walls of the operating room. He's an entrepreneur, the co-founder and CSO of Lylah Health, and a doctor who genuinely believes in meeting patients in the middle, bringing hard science to the supplement world and real empathy to the chronic illness journey. Dr. Bilal, or Doc, I should say, thanks for grabbing a seat with us today. You know, we got a lot to talk about, bro.
Yeah, we do. Yeah.
I just got to say, man, my biggest thing is to always have a cohesive conversation where we have the patients, the caregivers, and even the med pros to kind of come together so that we can change the way we healthcare. And you're a big part of that. So I thank you again for joining me at the table today.
No, I'm honored to be here. We had a little bit of chat beforehand and gelled, and hopefully you feel the same way. So, you can't change the system, and if you can't change the system, you got to bring all components of the system together and find a way around it.
Absolutely. All right, Doc. Before we get into the heavy lifting, all right, we're starting with a segment called the first sip.
All right.
We're playing a little game called Sweet or Bitter. It's a fan favorite. I think you're going to enjoy it. I'm going to name a health trend or a medical truth. If you love it or think it's actually helping people, it's sweet. If it's a total scam or just a headache for you as a doctor, it's bitter, all right? You got only 5 seconds per answer. You ready? And don't overthink, okay?
I'm ready.
All right, here we go. The first one. The Heart Healthy label on boxed cereal. Is it a sweet lie or a bitter truth?
That's a sweet lie, my friend.
Sweet lie. I want to explore that, but maybe that's a conversation for another time, right? All right, the second one. Biohackers drinking 12 ounces of olive oil. Is this the future or just a slippery slope?
No, this is a lie. Sweet lie.
Oof, sweet lie. All right, next one. The 10,000 step rule. Is it a sweet motivator or a bitter arbitrary number?
In between. And I can talk about that later because data has changed within the last year.
Okay, all right.
It's not a bad goal. You can do better, or you can better your health rather with less than that.
All right, next one. AI reading EKG reports. Sweet efficiency or a bitter robot takeover?
That is a bitter robot takeover. I'll give you a little snippet. I am on a project where I'm helping train those AI bots to do this, to read ECGs specifically.
Yeah.
They suck. So.
Yeah, hey, the Terminator. You gotta remember that. Next one. Taking 40 supplements before breakfast. A sweet ritual or a bitter waste of expensive pee?
Bitter waste of expensive pee. 40 is way too much.
Oh my God, yes. 40, that's a whole cocktail. Okay, all right. Next one. Doctor-patient direct messaging. A sweet connection or a bitter way to never have a weekend again?
Oh, it's a little bit of both. If it were used appropriately, it would be a sweet connection, and sometimes it is, but oftentimes it's a bitter waste of a weekend.
I can imagine that. I know my nephrologist. Sometimes I hit him up over the weekend. But all right. Hey, Dr. Hayes, what's up? All right. The apple a day proverb. Sweet wisdom or bitter propaganda from the Apple lobby?
I'd say sweet wisdom. It won't necessarily keep the doctor away, but it'll help you out.
All right. Yo, Doc, you survived. You survived. You survived. All right. Most of that was pretty bitter. All right. Which actually leads me perfectly into my first real question. You know, you clearly see a lot of things in the medical world that leave a bad taste in your mouth. So let's talk about the bitter reality of the operating room, okay?
Hey listeners, this is Michelle and you're listening to the Chronic Brew podcast.
You spend your days inside the actual structure of the human heart. After seeing the plumbing of so many people up close, does it change the way of how you look at someone just walking down the street? Or do you see the heart differently than the rest of us?
Yes and yes. This is something my wife tells me that I should probably tone down, but I tell her. I mean, she's in the medical field too. She's a doctor as well. Not a heart doctor, but anyways, I'll see somebody and I'll be like, I can from down the hallway tell you that person has sleep apnea or that person has high blood pressure or what have you. There's a certain kind of a lot of medicine is just pattern recognition, to be quite frank. And after you see enough patterns, especially when it's your day-to-day, yeah, absolutely. I can kind of profile somebody, and sometimes it's stereotyping, to be fair. But most of the times I'm right. And yeah, I think most physicians would say the same thing.
That's dope, though, because as far as like a quick profile diagnosis, it almost like streamlines how you provide care in a sense, right?
Yeah, it actually came in useful and was a little bit... hopefully she didn't take it the wrong way, but I think she may have. My aunt actually, my wife's aunt, she had asked me, do I have any medical issues? And I was like, well, I could look at you and tell you have sleep apnea and you have high blood pressure and you maybe have diabetes, and 2 of the 3 were correct. And the maybe diabetes, I'm glad I hedged. So she was happy at the end of it, but there was a little bit of
tension going on.
Love for a hot second when I told her that you look like you have sleep apnea. It's not something that somebody takes as a compliment.
Well, yeah, I hear that. I definitely hear that. But it's always good to be able to have those skill sets on hand just in case you need to do something super quick, really fast, right?
Yeah, I mean, and you'd think it would be kind of bare minimum at this point.
All right. Well, most people think of surgeons as being very matter of fact, right? You fix the problem and then you move on. But you've talked about having a deep sense of empathy for patients' journeys. Was there a specific moment or a particular patient that cracked that surgeon persona for you and made you realize that the system was missing something?
Yeah, I wish I could nail it down to one experience. I can give one experience, kind of this similar to what we had talked about earlier. But to be frank, I come from not a family of physicians. But my dad he just retired, but is and was a doctor. And I've been seeing the hospital from different perspectives since I was a little kid, since I was 5 years old. And for a long time, I didn't want to be a doctor. I actually wanted to be a writer. That went over well in my house. And as soon as I realized that there's not a lot of money to be made, or at least I can't support a family as easily being a writer, right. I went the medical route because there was already that seed planted. But I think reading people's stories, I was always a novel kind of guy when I was a kid until recently, where I went more nonfiction. But things like East of Eden, for example, by Don Steinbeck. I don't know if you've had a chance to read it, but it's this wonderful multi-generational kind of sort of autobiography, but a little bit fictionalized, where he talks about kind of the flaws in human character. Stuff like that, my passion that already existed, I think colored the way that I practice medicine, because it's your outlook. It's all about your outlook. And having the person in front of you on the cath lab table is one thing. You definitely have to be efficient and have kind of a proceduralist mentality. Otherwise, you're not going to do very well for the patient.
Right.
Outside of that, people are people, and they're looking to you for their health. And that's a really big responsibility. And to not take that seriously and give it the time and effort is a shame. Unfortunately, the system has incentivized, kind of like, we've spoken a little bit about this, but has incentivized people being more efficient. And efficiency usually translates to not listening to the patient, because you have 5 to 15 minutes for a patient visit. And patients feel bad, because when I'm a patient and I'm on the other side, I forget about the efficiency, and I'm like, I want what I paid for. I want my time. And when I don't get it, I feel upset, and so does everybody else. So I try to keep that in mind. And I think it's just basic human decency.
Yeah, for sure. I think especially, one time I had a conversation with another guest, we talked about the conveyor belt, syndrome, where we go into the doctor's office, it's 15 minutes, write script, goodbye, and there's never room enough for validation. And so that's one of the biggest frustrations I know a lot of patients have. I know a lot of caregivers have that same frustration as well. And it sounds like you carry that same burden of frustration too.
I mean, historically, even these days, trainees were and are called house officers. And it used to be a literal term, like you would be in house, essentially on call all the time. Turns out that's not a great way to have a family life. My wife and my kid would hate me if that were how things were. But I think we've swung way too far in the opposite direction, where people treat it like a 9 to 5. But patients, unfortunately, have health issues outside of business hours. You know what I mean?
Yeah.
And not, there has to be a way to reconcile that. A lot of it is driven by the way that people are reimbursed within the medical field. And that's unfortunate. Financial incentives work for a reason. That's why they're made. But you can't look at it like a job. You have to look at it like a calling. There's this common saying in medicine, there are much easier ways to make money than medicine. Some people have unfortunately kind of proven that wrong. Shout out to Dr. Oz. But it should be a calling, and it shouldn't be a focus on what incentivizes revenue. You have to some degree, to keep the lights on in your practice, but you're seeing patients at the end of the day, and that's your job, and that's your ethical kind of responsibility.
Phenomenal. Doc, you have this great phrase about meeting patients in the middle. In a world where doctors, usually stay on their side of their desk, and a patient are left, to Google their symptoms on the other, what does the middle ground actually look like for you in your office?
Yeah, it's a great question. It looks like a few things. So patients will come to you with questions, and often they don't know the right question to ask because they don't know about their condition. It's a newly diagnosed condition, or they're kind of caught up in the chronicity of it, which I'm sure you can understand completely. So something that I like to do is no computers. I'm not looking at a screen. I'm looking at the patient, and I'm talking to them. If I have to have a recording device to be able to refer to later when I'm dictating, so be it. But it's really important for me to be able to make eye contact with the patient, see the nonverbal stuff, so I can see if they're kind of holding back something that maybe they want to ask, and maybe I can fill in, the blanks, having seen, so many different versions or kind of stereotypes of that disease. That's one thing. Second thing is I carry this little whiteboard around with me. And what I've found is that we, as a profession, don't give patients enough credit. We treat patients, honestly, like they're stupid sometimes. And that's not the case. People are willing to learn in the right fashion. And so if there's complex anatomy, or whether it's a flow chart that, hey, you could do option A, option B, or option C, drawing it out after the fact and showing them seems to, at least from my experience, resonate a lot with the patients. And it seems to educate a lot better than just talking at them or being prescriptive. There's this term paternalistic in medicine, and we're taught, and at least in the last 20 years, I think there's been a movement to be more involved in shared decision making between yourself and the patient. It's more a curriculum thing and kind of goes away and dies in practice. But that's the way it truly should be. You should tell the patient what the options are. An example that comes to mind, probably like 3 or so weeks ago, I had a patient who is 78 years old. Obviously won't give more information than that, but
HIPAA.
HIPAA, exactly. Not trying to have a lawsuit, but she had there are two types of heart attacks. One that is 100% blockage. That's an emergency. You have to take them to the cath lab immediately to save heart muscle and potentially a life. Right. And then there's a heart attack that's not 100% blockage, but it's enough that it requires treatment. And you either go in and you put in a stent, or you treat with medications. She was adamant. She didn't want a procedure. I'm a proceduralist. I see a nail and I like to bring the hammer out, So
Yeah.
the first thing I offered, because it's the right thing to offer. But she told me, she was like, hey, I walk around alone in my home. I've got, a home health aide who comes to help me. I have somebody who comes to help with cooking, shopping, all that stuff. She's got a walker. I was like, do you, like, when you're walking up and down the halls in the hospital, do you feel like you have the same quality of life that you would have at home? And she was like, yeah, I think I do, because I don't get around more than this. And I'm not having symptoms. And so thankfully there was data to inform it too. We're able to meet each other in the middle. In JAMA Cardiology, one of the cardiology publications, I think 2 years ago, don't quote me on that, there was a study looking at specifically this type of heart attack and how to treat people who are 75 and older. And it turns out that it was equivalent, or procedure was equivalent to medical therapy, because people are frail when they're in their 70s.
Right.
People don't handle procedures as well. They don't have as much of a life expectancy left compared to a 50-year-old, so on and so forth. And so after about 30 minutes of haggling, I was like, hey, actually, what you're saying jibes with the data. So why don't we do this? I'm not going to do a procedure. You've completed the 48 hours of the blood thinner to stabilize the plaque. You go home, and if you have symptoms that are limiting your quality of life, you call me, and we'll go back to the drawing board. But there's always a way out. There's very rarely is there a way not to meet patients in the middle, especially with so much data available these days.
Yeah, one thing I feel like a lot of doctors miss out on is the opportunity to create more advocates. I feel like there's a part, just like you mentioned, the patient is able to learn as long as you're giving them the opportunity to explore what's really going on with them. It's almost like bringing the patient on the side of them. If you can sit with them and map out all the things that are going on with them and encourage them to educate themselves on what they're going through, they then kind of foster this, energy to want to be more of an advocate, not just for themselves when they go to doctor's appointments, even to their family members, even to kind of share. And that's an extension outside of the hospital, would you think?
Absolutely. It's an extension. The support network that you have, family, friends, trusted ones, that's unfortunately as impactful in terms of making good decisions and bad decisions. I see that when patients will come and they'll have, 10, 15 family members around them, and everybody has a different opinion. You have to corral everybody to come to the right conclusion. I think surrounding yourself with people and kind of knowing who to rely on for certain things. I'm going to rely on Uncle X for all my mechanic work, but I'm not going to trust him when it comes to my healthcare kind of deal. That's sort of on the patient, but clinicians also have to be able to filter through and be like, hey, this person is a loud voice, but maybe not a voice that's advocating for what's in the patient's best interest. So often what I'll do in kind of contentious situations, if there's a few family members who are really kind of going against the grain and the patient seems to be influenced, I'll say, hey, why don't we clear out the room and I'll just talk to the patient one-on-one. And they'll usually take you up on that because they're like, I'm confused. I want to kind of hear it from you first and have some time to think and breathe. That usually solves the situation. Not always, but sometimes you have to be harsher. There's a unfortunate story from about 5 years ago where I had a patient that was awaiting a heart transplant and needed to go on heart-lung bypass. And I'd been coordinating CPR for about 30 minutes, and both of her daughters were lawyers. And this was still COVID restrictions where they couldn't come up to the floor. And so they're calling and yelling and screaming and saying you have a lawsuit on your hands if you touch her.
Oh my gosh.
Without us present. And I was like, I had to be curt. I was like, my friends, she's dead. Like, she has no pulse. We have to do CPR. And it was a sad ending. She, got on heart-lung bypass, got off heart-lung bypass, had to go back on, was successfully taken off. This is 6 months later, and then died of an infection waiting for a heart transplant.
Oh.
It's the worst day of someone's life, and they're responding emotionally like we all would. And it's hard to corral, but sometimes you have to be stern about it.
I wanted to take a side quest, but I want to make sure I honor your time. But just real quick.
I got until 3:00 Eastern.
Okay, so like just quick side quest. You mentioned when you worked out all the kinks and you did everything you could just to hear that a patient of yours ended up passing away. just touching on the empathy part, like what, how do you carry those things? Like, how do you carry that, knowing that your patient passed?
Yeah, it's easy now because it's default, right? At the beginning, it was really, really hard, and I'd say for the first 3, 4, maybe even more years. Same with my wife. We would have, to be quite honest, just sob fest. We'd come home and we'd be like, I'd tell her about a bad patient encounter. She'd tell me about a bad patient outcome, and we would just cry. And there's no shame in saying that. It's a human life. One that I just hate because I didn't know enough. It was within the first 6 months of my training, so I'm fresh out of medical school. I know just enough to hurt somebody. You know what I mean?
Yeah.
I need the supervision. That's why there are training programs. But there was nobody at night in terms of an attending physician or the senior doctor. It was another trainee with 2 more years of experience. There's this guy who had a procedure to basically look at a pancreatic duct. They weren't sure if it was cancer or not. So just procedure just to get a biopsy. Ended up not being cancer. We didn't know what he was in the hospital for, but he had belly pain, and all of a sudden, a little bit sleepier. He's requiring oxygen, which is weird because he's a healthy guy. And so I asked, my senior, I'm like, hey, something's going on here. I don't know enough to put it into words yet, but he's on oxygen, and what should we do? And she's like, oh, it's fine. It's a little bit of oxygen. It's 2 liters, not a big deal. I'm off the next day, and I check, and he developed pancreatitis, iatrogenic or basically procedure-caused pancreatitis. In the ICU, ended up passing. They had surgery came by and did a bedside open abdomen to try to decompress. He had something called compartment syndrome, where basically there was so much fluid built up in the belly that it caused pressure on all the organs and put him into multi-organ failure essentially.
Right.
But they weren't able to do, by the time the knife got to him, it was too late, and he ended up passing. I cried like a baby that night because it was I knew something was wrong. I just didn't know enough to act on it, and I wasn't in that position. But huge regret of mine. So.
Yeah, that gut instinct when it hits us, and we know, it's like spidey senses,
Yeah.
Gosh.
Something doesn't make sense, but I just don't know what it is yet. And as time goes on, you learn to compartmentalize. But yeah, it's hard to carry. It's still there.
yeah, for sure. Let's jump into the next one. It's almost like the chronic blind spot, right? You know, right? In the world of cardiology, all right, we're great at the emergency, right? The heart attack, then the sudden fix. But for the people listening who have or live with chronic conditions on a day-to-day basis, where do you see the biggest gap in how they are being cared for?
My man, there are many, many big gaps. Let's
go
down the list. Providers don't communicate. Primary care providers, not necessarily through faults of their own. The system has changed where they're not the focal point. They're not the people who know you the best, who can kind of manage all the different specialists that you have. They're kind of a hub for a click in the electronic medical record to refer you to somebody. So a lot of referrals that I get are just somebody saw something, they didn't have enough time or whatever the circumstances were to look into it further. And they're just like, I don't have time to deal with this problem. You take this problem.
Pass it along.
Just pass it along, pass the buck along. And then the communication is lacking too. I'll put something in the chart, and you would think someone consults somebody and they, ask for a service that they would read what's written in the chart. I'm a little bit sassy in the sense that I bold the stuff that really, really matters. And it often just goes overlooked. And I've spoken to at the current institution I'm at, I've spoken to some of the hospitalists, and I'm like, dude, I'm writing my note. It's in the note. Why? It's not just for billing purposes. It's also so And they're like, oh, well, we have so many patients, we don't have time to read the note. And I'm like, but
easy grounds for medical malpractice.
Right. It puts you into so many layers of trouble. Patient care is not coordinated. They're not discharging the right medications. If I start putting orders in willy-nilly, it's like having too many cooks in the kitchen. I put in an order, and somebody else puts in another order, and now all of a sudden nurses are calling both of us, like, which one is right? And it's like, we haven't had a conversation yet. Like, let's sit and talk about the patient. One kind of funny example is because a lot of this, I have a feeling, is going to have a kind of a morbid feel to it.
Bring it on.
I got this consult for chest pain, and I call the doctor, and I was like, tell me about it. And she was like, I'm not used to specialists calling me to clarify, because I'm in a private practice, and you make more money when you see more consults. But I was curious, and I was like, tell me. And she's like, well, I'm not sure. Like, I haven't really talked to the patient myself. She just endorsed chest pain to one of the nurses. And I was like, cool. I go and see the patient. She's there for standard chemo. Like, it's not an admission for anything like an illness. And I asked her, I was like, do you have chest pain? I asked her in every way I can think of. And she's like, no. And I was like, did you ever tell any nurse that you had pain? And she was like, yeah, I have pain right here in my side and my back, which is chronic and has been going on for 15 years. I had to do my due diligence. I was like, is it any different in character? Like, does it feel different? Is it worse when you exert yourself? All the kind of heart-related questions. Turns out, no, just standard back pain that she's had for years. And that was a consult for chest pain. I was like, it's the easiest consult in the world. But like, I asked the question for a reason.
Oh my gosh.
Yeah.
Okay. So, and these are real takes that happen in the medical setting, right? And we know,
not made up. Yeah, I can't make these up. You know what I mean?
Like, this didn't come out of a book, right? And we know that doctors are human. They're not perfect in a sense, in a sense of the word, but to make mistakes in that, like, what if they had to go to surgery, chest pain? Okay, we have to open heart, when all along it was a back situation. Like, the misdiagnosis part. There's so many stories and cases where there have been misdiagnosis, which led to other, conditions later on. And then, the L word lawsuit, kind of came into the picture. I think, and you and I can agree, that's something that, new doctors coming in might want to be very careful of, to not make those mistakes.
Absolutely. I actually had a really close friend of mine who practices in rural Florida, not too far from where you are, actually.
All right. Yeah, we're pretty rural.
Yeah, I mean, a little bit more rural, though. We trained at the same institution. He was a year senior to me, and someone I really looked up to. And he just called me out of the blue, and he's like, hey, man, how's it going? Turns out he's changed jobs, and I asked him why he changed jobs. I won't go too much into the details because there's an active lawsuit and investigation.
Yeah, allegedly.
Allegedly, there was some Medicare fraud that happened. But the point of the story is he's now got a thriving solo practice. He's bone tired because he's on call every day. Yeah. But the punchline was, he was like, I'm not even a good doctor. I'm just doing the bare minimum. And that's orders of magnitude better than everybody else around me. And that's just a sad state of affairs. And that's what I tell patients. I'm like, it's legitimately the bare minimum. I'm not offering you anything more than what I see as my responsibility. And that's sad that is somehow, new or magical to you,
You'll be surprised. Just a doctor saying, how are you doing, can sometimes change the world. Trust me. Yeah, I've heard conversations, but you're a busy guy, with a demanding medical practice. My question for you is, why take on the headache of a startup? What was the broken thing in the supplement world that frustrated you so much to the point where you felt like you had to build Lylah Health to fix it?
Yeah, it's a great question that I ask myself every day. Why did I do this? But a few answers to this. I actually didn't get to the supplement industry being broken until a little bit later in the course. It actually started as research that I did with some of my colleagues back in 2017. We were looking at the gut microbiome. People have probably heard that term by now. And what, perturbations or differences in what kind of bacteria are growing and what abundance, and then what their metabolism looks like what chemicals do they make, which actually do the health effect, whether negative or positive. We were looking at people who were getting a heart cath, or basically procedure to look at the arteries of the heart. We got a rectal swab to do what's called 16S sequencing to see what kind of bacteria are growing, and then something called metabolomics to see basically what kind of products bacteria are making after they ate their food, or basically fiber.
Right.
And then we stratified by people who got heart caths and had clean arteries and didn't need any intervention, or people who had blockages and needed a stent. We were about 3 patients away from finishing the study, and then COVID hit, and funding got appropriately kind of redistributed to COVID-related stuff. But that passion project kind of stayed on, and I just couldn't get around this whole, you may have heard, kind of cut after cut after cut to NIH funding, where only certain things are funded, and things that are important are kind of left by the wayside or more investigational. Basically, it benefits pharmaceutical companies more than anybody else. Regardless, I thought, let's go the industry route. I can't let go of this idea. I think it's a compelling idea, and I think it's one that works. The only place I could go was the supplement industry, and that's when my eyes really opened, because I was never really a supplement guy myself. And I started looking at different companies that would be considered like competitors down the line. And the theme was all of their data. They were like, we're science backed, but the data is in like tiny 100-point smaller font with a little asterisk. And then I'd Google the studies and be either unable to find them, either on Google or PubMed, which is like where all medical literature is indexed. It's kind of like a search engine for medical studies. Or I would find something that's like in mice. And it's like, well, we're not mice and we don't have the physiology of mice, so it doesn't make sense.
Yeah.
So it became clear very quickly that this is a whole lot of horseshit. And being, sold snake oil for a lot of money for the average person. And so that kind of spurred me to continue to do it. And to kind of see it to the end, because there's not only that, patients in clinic will often ask me, because we get a medication list, and they'll bring their supplements and they'll ask me, can I take this supplement? I used to not know anything. Now because I'm in it, I know a lot more and I can tell them. But there's this great study in the last 5 years out of Circulation, a cardiology journal, that basically showed that 57% of people who go to cardiology clinics also take a supplement that's meant to support their heart health. So clearly people are looking to different places for solutions for problems, and rightfully so. You can't blame them. It's not a one-stop shop at your doctor's office. But if 57% of people who are going to the clinic are taking a supplement and they're being sold something that they're basically pissing out or shitting out, like that's doing no good to anybody except for lining the pockets of the company.
Yeah.
That's where that meet in the middle comes from. Is, I really saw it as an opportunity to be, I don't know if there's any other clinician who's doing this, but I'm the only one that I know of personally, who can come to somebody and say, hey, I have this training, but I can also show you something that's evidence-based, fully transparently. Our internal and external mantra is actually no bullshit ever. So like all the studies, I have them on my website. I will show you and cite whatever needs to be cited, but you deserve to demand more from your supplements. It should be, more properly regulated, and it's not. All you have to do to be compliant with the FDA is not make certain claims. That's about as low a bar as it gets.
That's a slippery slope too.
And you don't have to be third party tested. You don't have to be this. You don't have to be that. Like the things that should be bare minimum are not. So that's what kind of spurred me to take on the supplement space. Not take on necessarily, but enter it and hopefully be big enough to take them on at some point.
A little bit of taking on, right?
Hey, my name's Dr. Bilal Ahmed. I'm an interventional and structural cardiologist. That means I open up arteries during heart attacks and replace heart valves. I'm also co-founder and chief scientific officer of Lylah Health. It's a supplement that's aimed at both heart and gut health. It's a prebiotic or fiber, a probiotic, a blend of probiotics or bacteria, and postbiotics, the chemicals that bacteria make after they eat that do the actual health action. It's evidence-based, and our mantra is no bullshit ever. That means I'll educate you. All 79 papers that were used to formulate this are available on the website through an AI chatbot. Ask it questions, ask me questions. And if I had one thing to tell you guys, demand more of your supplements, demand more data, demand more transparency.
I got to be honest, Bilal, like the supplement aisle is like super intimidating, bro. It's full of big promises and, like you said, the very little proof, as the big, or I should say, as the guy bringing hard science to that space, what are the 2 or 3 things you wish every chronic illness patient knew before they spend another dollar on a bottle of vitamins?
Any supplement that is selling you a quick fix almost certainly does not work. There is no such thing as a quick fix when it comes to your health. That's just
Wow.
the way it is. There are a lot of, without naming names, there are companies out there that'll say, take this product as a 7-day reset for whatever, your gut or your heart. And it's like, that's not how the body works. Like there's still certain things that you have to do. You still have to try and make an effort to eat healthy, to live
Absolutely.
a somewhat active lifestyle. Like this is not a silver bullet, and I'm not selling it as that. I'm selling it as like, you have to do some hard work, and this will be, incrementally beneficial, even more beneficial if you do the hard work.
Right.
That would be kind of number one is, if they're selling you a quick fix, it's not a quick fix. It's probably placebo. The second thing I would say is, kind of harking back to patients know more than they think they know, or that we give them credit for. Look at the studies that they're citing on the website. Try to Google it. If you can't find it on Google, or if it's all just publications or PR press releases from that company, it's probably not real data. I think those are 2 quick and dirty ways to screen for something that works or doesn't
Right.
work, at least.
Now, I do want to take you up on your opinion on Google. All right. Now, a lot of times we kind of sometimes feel like we get left in the dark when we go to our PCP or we get some instructions from the doctors. And sometimes we resort to Google just because Google's a little bit more friendlier or, very benevolent with information. And so we try to be those folks who just want to be proactive with our health. What is your definitive response to patients going on Google to, find answers that they're not getting from their doctor's office?
Can't say I blame them. I mean, you're going to look where information is readily available, I would caution, especially these days, ever since the AI overviews came out, most people use Chrome as their browser. I don't have that AI overview shut off. I don't know if there's a way to do it. There probably is. It's incorrect. Almost like at least 50% of the time, what it's spitting out is not something that you should be relying on. So I would caution patients that, hey, I understand you have to look for information. Educating yourself is great. Skip over the AI overviews. Go straight to the links. Try not to go on somebody's blog unless you know for a fact it's somebody who's trusted or someone who's won your trust. Things like Mayo Clinic, for example, links to kind of reputable sources are better than kind of Good Housekeeping blogs. You know what I mean?
Yeah.
Or cosmopolitan blogs. But like you'd be surprised where people get their information and kind of tout it as like the ground truth that prevails over all other truths. So yeah, I mean, I can't blame people. You have to find information, but to patients, I would say come with that information. I welcome that information, but don't be offended if I dissect some of that information and kind of redirect you.
Yeah. And I think you pretty much you kind of jumped ahead of the question I was going to ask next, which was pretty much filtering the noise, which is great. Our listeners get health advice from everywhere. TikTok, right? Their neighbors, their maybe their pet cat. I don't know. Even their doctors. Since you value that patients look at multiple sources for sure. How do you help them figure out who to trust without just telling them only listen to me? I think you hit it on the head.
Yeah, I mean, to add to that, I do not want to get political under any circumstance, but it's we all know that there are trends like not believing in vaccines, for example, that lead to real health outcomes, whether or not people believe it. Like we had our first measles outbreak in decades to a half century in Texas for a good reason, because there's a whole community that wasn't vaccinating. I get that there are a lot of unanswered questions about COVID, but before that, people seem to be pretty okay with vaccines. We know for a fact that original study that linked vaccines to autism was completely literally made up to serve a certain purpose or a certain opinion that one person had, and that's been taken as the ground truth. And a lot of people who say they do their own research I find are listening to talking heads, whether it be on, a certain news channel or TikTok or what have you. I would, again, with the other caveats, I would caution against that and say, fine, listen to what you want to listen to, but try to verify it. Try to look for something.
Right.
Some of the
Do the
scientific
homework.
literature is hard to parse through for somebody who's not trained to read through it, but you can at least get through kind of the introduction and the conclusion and make some sense of it. And we have AI tools these days. Don't rely on them 100%, but you can feed the paper to the AI tool and say, summarize or explain like I'm 5. I do that for like financial stuff and taxes, stuff I don't know anything about. I feed it that, and at least I'm a little bit more informed when I go to, H&R Block or what have you and say, hey, like this is what I think I can do, but I don't know, you tell me. That's the kind of attitude I would adopt, without the ability to completely overhaul our education system. Because currently we're, at least when I was growing up, we were getting our health education from our gym teacher, and our gym teacher was not the person to rely on. It was mostly a sex ed class, and
Right.
no real nutrition or any usable information there. But given the system we live in, do your research, but also know that there's a reason people have expertise, right? And while you can't necessarily say every doctor is the same type of expertise, you also get that feedback about how they make you feel. So if you find a doctor that makes you feel like you're being heard and that you can trust them to decipher some of that, or maybe kind of debunk some of the things that you hold as truth, because that's just the reality of it.
Yeah, almost like it's always it's okay to unlearn something that you always knew was true, to learn something new. Wow,
that's science, actually. I mean, we're unlearning stuff all the time. Like stuff my dad learned is now false, and stuff that I learned 20 years ago probably will be false very soon. Yeah.
Oh my God. Like for me, like one truth that I just can't get over, or rather something that got debunked, was Pluto. Like Pluto. Remember when we were kids? Like 9 planets. It's stuck. I have a T-shirt. I have a graphic tee with 9 planets, and they telling me Pluto's not even. It's because it orbits Neptune. Like, okay, for me that was a planet, right? But anywho, my little soapbox with that. Don't judge me, guys. All right. Now,
I'm right there with you. I'm in the Pluto the planet camp.
Okay, so going back to you, and Lylah Health, right? Has being an entrepreneur and building a company from the ground up changed the way you walk into a hospital room? Or, does it make you more impatient with healthcare status quo or more hopeful?
Ooh, that's a good question.
I know, fireball. Sorry.
I don't think it really moves the needle in any direction specifically, because I was already pretty damn frustrated and remain so. To be honest, I try to divorce those two. I'm not in there to tell patients, hey, buy my product. Like that would just be abjectly immoral for me to try to peddle something while I'm in clinic. So I actually kind of keep it under wraps that I've got a company, I'm doing this, I'm doing that. Because most of the people that I'm seeing are high enough risk that I actually wouldn't recommend my product for them. This is more for people who want to better their health and aren't people who are high risk for having a cardiac event in the next 10 years. Those people should be on pharmaceutical agents that are proven and work stronger than what Lylah's offering does, and for a reason. So I guess the short answer is it reaffirms all the frustrations I already had. Doesn't necessarily make me more hopeful. It does give me an outlet that I know I'll have when I get home. So that's a little bit better. But yeah, it just reaffirms that the system is broken and there are other ways to do this. All
right. Bilal, before we take the very last sip of this conversation, I'm sorry I had to break it to you, but I've been secretly brewing something on the side, and it's time for the espresso shot. I had to bring it to you. I hope you drink espresso. If you do, it's going to be great. This is a 1 high pressure, 0 filter question. Okay, now listen carefully. I'm going to give you 30 seconds. Matter of fact, I'm going to set a timer for 30 seconds on my phone. Where is it? I'll find it somewhere. All right. You have to give me the most honest, non-doctor answer you've ever given. All right. You ready?
I'm ready.
All right. Here we go. Matter of fact, this is going to be called the human shot. Here we go. You're a world-class heart surgeon, but let's be real. Everyone has a junk habit. What is the one unhealthy thing that you do, whether it's a late night Taco Bell run or binge watch trash TV, that would make your medical board lose their absolutely crazy mind? The talk is ticking. 30 seconds. Go.
All right. I had not gone to a doctor or gotten blood work for the last many years since my pediatrician. And my wife, actually, a few months ago, was like, "You're a doctor. You need to get your blood work checked." Turns out I have high cholesterol. So I started a statin.
What have you been eating?
And I also take Lylah. Obviously, I have to. But yeah, they say doctors are the worst patients for a reason. I'll add a little bit of spice to it that I will deny in court if anyone says that.
You know this is going to be released, right?
It's going to be released, but at the risk of exposing myself, I vagal when I get my blood drawn, and so she's drawing my blood. I'm looking at it, and she's like, "Okay, now it's time for the urine test." I start walking to the bathroom, and everything's like tunnel vision. It's going black because it's like, the blood's supposed to stay in me. It's not supposed to come out. You know what I mean? And I'm like, I'm going to pass out, and I cannot pass out in public. And so I go into the bathroom, and I just like slow slide down. I'm like soaked in sweat, like breathing heavy. Gave myself 30 seconds, tested the waters. I was like, okay, I can stand up. Gave the urine sample, came out hopefully cool as a cucumber, but probably sweaty and like frazzled. So yeah, if you don't like getting your blood drawn, there's someone who sticks blood vessels for a living who also does not like getting his blood drawn. So
that is the most oxymoronic thing I've ever heard in my life.
I'm ashamed, but hey, you asked for the truth, the unfiltered truth.
All right. We're good. I love it. I love it. It's good to know that the guy who's fixing our hearts is actually human, right?
Yeah.
It's good to know that. Oh man. Now that we've got that jolt of energy, right? Let's bring it home for everyone listening who's struggling today. All right. If you could sit with the person who feels like they're, failing at managing their chronic illness, and give them one piece of truth from a cardiologist's perspective, what would that truth be that you want them to hold on to?
So that's a really good one. There are a few pieces of truth, but I think one for chronic cardiac patients is pill burden. If you have heart failure, for example, there's a standard 5 medications that are going to be pushed to you immediately. And that's often, especially for a newly diagnosed person, that's new. That's a whole regimen that they have to manage. And what I like to tell patients is, this may not make it any easier, but medications don't have a moral component, right? They're not good. They're not bad. You either need them or you don't. And seeing it as a weakness or a crutch is the complete wrong lens to put on. It's something meant to help your health, and if you need it, then it's going to positively impact you down the line, or at least keep you from getting worse. And so no need to be ashamed. No need to overburden yourself. Try to stick to your regimen, but if you miss a pill or two, at least be honest about it, in the visit, because sometimes it can have an impact on what we're going to do. Some medications you shouldn't miss any doses of, but we can always fight through. Honesty is kind of the best policy, and being human is acceptable.
That is such a powerful take because of the fact that I know, like even my dad, he gets prescribed glasses, and he does not like to wear them for the reason of he's lived his whole life without having to wear glasses. I mean, guy's 67 now, right? So he needs glasses, and so just him doing that, and I know a lot of folks who take a whole tray of medicine in the morning, and sometimes when it comes to traveling or being around friends, and when it's time to take medication, they really don't want to take it in front of them, because it's that sign of like, I'm weak or my body's breaking down. They don't want to seem frail in any way. But that's such a powerful take because it reminds us that these are just tools to help us to continue to thrive, not necessarily to put a label on us per se, outside of the diagnosis.
Yeah, it's a beautiful way to put it. I think better than I put it. Yeah.
Stop. You're a doc. But I appreciate the sentiment.
From someone who's suffering from a chronic illness, that's, you have better words than I do. I'm not the one in your shoes,
I appreciate that, man. Yo, Bilal, this has been such an incredible cup of coffee. But before we let you go and get back to the hospital and the labs and all that jazz, right? I want to make sure people know where to find you, whether they want to follow your journey as a surgeon or see what you're building with Lylah Health. Where is the best place for our listeners to connect with you?
Yeah, so for what I'm doing, if you want to see what I'm building, LylahHealth.com is the way to go. LylahHealth.com/blog. No AI assistance, no ghostwriter. It's just me, myself, and I. The studies, all the claims I make are hyperlinked, so you can read the studies, yourself as well, and kind of to the point of education. I always tell people, feel free to email me, Bilal@LylahHealth.com, and I've gotten a few medical questions that way. And I'm active on LinkedIn. It's Bilal Ahmed. That's where I do a lot of my, the little newsletter called Prescriptions for the Heart, which is a lame name, but I try to do a little bit of educating there. I've never been able to be the kind of social media TikTok type of doctor, so I write stuff. Yeah.
Right. Perfect. We'll make sure to drop all of those links in the show notes so that everyone can find you with just one click. And to everyone listening, chronic illness can feel like a full-time job where you're the only one who's working or the only employee. But as Dr. Ahmed reminded us today, there are people out there at the very top of the medical world who aren't just looking at your charts. They're looking at you. So don't be afraid to demand the middle ground in your own care. You deserve a doctor who brings both the hard science and the human empathy to the table. Peeps, thank you for joining me and Dr. Ahmed, or Bilal, or Doc as I call him. This has been another great episode of the Chronic Brew Podcast. We hope this conversation gave you a little bit more energy for your journey ahead. Until next time, keep advocating, keep questioning, and keep taking care of your heart. We'll see you on the table next time. Remember, grace on repeat.